Well, welcome everybody. This is Dr. Ramirez. We're doing an unknown session here. Some interesting cases, infectious cases, which will be a hodgepodge of things ranging from bacterial, fungal, parasitic. So it should be pretty interesting. And without further ado, we will go ahead and get started. And I just wanted to give a shout out to Path Presenter website for the slides I collected. We have about 21 or so to do. Very nice collection of educational slides. So check it out if you have a chance. So this is case number one. And again, as usual, what I'll do is start out with the sort of salient features and things that I see and kind of develop maybe an approach, recognize patterns and see how would I approach a slide, what would I do next. So looking at this one right here, I see a couple of things. I see a psoriasiform hyperplasia. We see these elongation of reedy ridges. And there's also a very dense and brisk band-like lymphocytic infiltrate, which has areas of darkness over here, which represent the lymphocytes, and some areas of pallor, which are actually, in this case, also lymphocytes. They're activated lymphocytes, but kind of look like histiocytes in some areas here. So this combination of psoriasiform and lichenoid pattern is an interesting one, is one that you should keep in the back of your mind. You can go through the differential individually from the psoriasiform side, so things like psoriasis, or from the lichenoid side, so things like lichen planus, pityriasis, lichenoides. But keep in mind that the combination really should bring to mind this condition, which is a secondary syphilis. So interestingly, in this case right here, we actually don't have a lot of plasma cells, which is what we often hear the textbook talk about. And it is actually often the case that we see plasma cells. But I thought it was interesting that this one didn't have as many plasma cells as we're used to seeing in secondary syphilis. Here's another case right here, which actually has the same pattern. We can see that combination of psoriasiform and lichenoid or band-like pattern. So keep that one in mind. This one more darker. The infiltrate has this darker appearance. And that's because if we go closer, we can see that there are quite a bit of plasma cells here, nicely represented. Perinuclear Hoff, eccentrically placed nuclei. So this case is one where you should definitely think about doing a spirochete stain. Although keeping in mind that at about 30% of cases, the spirochete stain will be negative. So you just want to remember that not all cases are going to be positive. So if you have a high level of suspicion, you may want to suggest them to do the serology studies. So here's kind of the outline of what I was just talking about. Remember that psoriasiform and lichenoid pattern syphilis is really the inflammatory condition that is a great mimicker. So you have to have a high index of suspicion, which will be a common theme with a lot of these infectious processes. We mentioned things in the differential diagnosis. In some cases, you really don't even see much epidermal involvement. In fact, you can kind of get this coat sleeve dermatitis, which I'll show you an example right here. And this is an example, another example of syphilis, but you can see there's not much of that psoriasiform or lichenoid pattern, not much epidermal involvement. You sort of go down the differential diagnosis of the L is a superficial and deep perivascular lymphocytic infiltrate. With the exception that in addition to lymphocytes, you have actually the majority of cells are made up of plasma cells. So that's really your clue here. Basically, these are all plasma cells in this field right here. So that is an example of this more superficial and deep pattern of secondary syphilis. So keep that in mind if you're seeing plasma cells. Your differential diagnosis can include other things in the L's, things like EAC. So again, have a high index of suspicion. We talked a little bit about the immunostain. Neutrophils in the scale, sometimes you'll see that as well. So that's another thing that if you see newts in addition to the traditional things we think about like psoriasis, dermatophyte, keep secondary syphilis in mind as well. And also in cases where you get many organisms, you can have this rapid negative or false negative rapid plasma secondary to antigen excess, or otherwise known as the prozone phenomenon. So you may want to communicate that to your clinician if that test is negative and you have a case where you have a high index of suspicion, which would be something like this right here. Okay, so we can go ahead and go on to the next case. So here we see a fairly unremarkable epidermis, and we see a pretty brisk dermal infiltrate. Again, some areas of pallor, some areas where there's a little bit more dark staining over here. And we can see in the areas where it's a little darker that we have clusters of epithelioid histiocytes. So epithelioid basically means cells that are roughly the size of, or maybe a little bit larger than a keratinocyte. And they have this very abundant pink cytoplasm. And so when they cluster together, we call that an epithelioid histiocyte. We have areas over here where it's a little bit more pale. So anytime I see this kind of granulomatous inflammation in the dermis, I'm starting to think you better look for infectious things. So as we scan around, sometimes we'll need our special stains, but we get lucky enough sometimes where we can see the intracellular organisms right here. And these are all intracellular, probably, I'm guessing, about 2 to 5 micrometers in size. And this kind of pattern right here should really bring to mind the parasitized histiocytic histiocyte differential diagnosis, which we'll talk about in a little bit. But this in particular happens to be a case of histoplasmosis. So histoplasmosis, these patients generally live around the Ohio or Mississippi River valleys. They get these inhalation of spores from the bird or bat excreta. And as we'll see with a lot of these infectious things, especially with the lungs or with the fungus, the lungs are the primary focus of infection in many cases occurring in immunosuppressed patients. Cutaneous disease occurs in less than 5%, again, as a secondary phenomenon. Sometimes you'll see this clear halo surrounding the histiocytes. And as I said earlier, the bugs measure about 2 to 5 micrometers in size. A GMS stain will highlight them nicely. So again, the parasitized histiocytic differential diagnosis, I said we'd talk a little bit about that, but whenever you see this kind of pattern right here, where you see a lot of bugs within the histiocytes, think about the differential diagnosis, which is right here. Histoplasmosis. Often the big thing for me is leishmaniasis, because it can look similar to histoplasmosis. It can be difficult to tell the two apart. You'll read about the kinetoplast, the 2 dots that you see in leishmania, but honestly, it's such a small bug that I think it's very hard to see that. What I find more helpful is this marquee sign, where you see the bugs lining around the edges of histiocytes, and we'll see that in a little bit. Penicillium marfinii can look similar to histoplasmosis. You get the addition of formation of septae. Granuloma inguinale and rhinoscleroma are both Klebsiella-driven processes. In granuloma inguinale, you get the Donovan bodies, which are bacteria. In rhinoscleroma, you get the muculic cells, which are these foamy cells, and they'll also be accompanied by quite a bit of plasma cells, which have a lot of these Russell bodies, and they have this sort of pregnant plasma cell look to it. And toxoplasma is pretty unusual in the skin, but to complete this list, we should include it. So we can go ahead and move on to our next case. So here we see another unremarkable epidermis and a very brisk dermal infiltrate, and sort of that pink quality over here, so we can qualify this as granulomatous infiltrate clusters of epithelioid histiocytes. And we see some empty spaces as well. And if we go close to those empty spaces and start to look, we can see these little dot-like structures, not the best represented here, but we may want to think again about going down our differential diagnosis here for parasitized histiocytes, which would be a good idea in this case. We can go to another slide actually of the same process right here, but I think a little bit more nicely represented. Again, the very diffuse granulomatous infiltrates some paler areas. And if we go closer, you even see some multinucleated cells like right here. But if we go closer to the paler areas, we start to see that, again, we can think about our parasitized differential diagnosis. And let me see if I can find a better area here. Maybe in this area over here, where we can see some organisms within the actual cells. And over here in particular is really nicely represented. And this is actually good because it has what I was talking about earlier, this marquee sign where you see the intracellular bugs kind of lining up around, almost like a palisading around the periphery of the histiocyte. So this is leishmania. It's a protozoal infection, single cell organisms, flagellates actually, and you get a brisk lymphohistiocytic infiltrate, sometimes with plasma cells. And again, we want to think about our parasitized histiocyte differential diagnosis. In some cases, you can get to leishmania, which has quite a bit of granulomatous inflammation that resembles sarcoid or TB, so keep that in mind. A lot of the theme with these infectious things is you have to keep a high level of suspicion. So in particular with leishmania, if the patient's had a travel history, or as we saw with histoplasmosis, if they live in an endemic area, that really comes to play and is very, very important in making the diagnosis in these conditions. And something that's been recently in the literature is this, some clones of CD1A are positive in leishmania, so you can use this to help you make the diagnosis. But often we rely on PCR, which is a very, very good test in IDing these things. Okay, so we can go on to our next one. So here we can try to gather as many clues as we can from our biopsy as far as the site, and we can see here that there's cartilage. So it's probably coming from the nose, possibly from the ear, but the pathology really is up here. So it's very obvious that there's a lot of inflammation over here, some very dark areas in zones over here. And if we go close to those zones, you can see right here that these are actually all plasma cells. So they have that nice clock face chromatin. They have that good perinuclear HOF in some areas. So these are all plasma cells. So we can decide that there's a very heavy plasmacytic plasma cell infiltrate. But in addition to that, there's some pale areas. And pale areas are nicely juxtaposed to the darker areas over here. And these paler areas are kind of these larger foamy cells, nicely intermixed with the plasma cells, which are over here. And these are what we call the Mikulicz cells. So we were talking about this earlier in the context of rhinoscleroma, which is what this is. So rhinoscleroma is this chronic inflammatory disease involving the nasal and oral mucosa. It's driven by a Klebsiella. It's endemic in Africa, Asia, Latin America, and is spread by direct contact. So not too commonly seen in this country. So we talked about the Mikulicz cells, which are the cells that have abundant organisms. That's why they have that foamy look to them. And the plasma cells with the Russell bodies. And as a matter of fact, I think we can find some plasma cells here that have Russell bodies because it's good to see them. There they are, a couple right there. They have all this pink staining immunoglobulin material within them. So it's very nicely represented there. Here's another one over here. So remember that. And then also there's this talk about rhinoscleroma kind of being related or maybe triggering Rosai-Dorfman disease, which is, I thought was interesting because in Rosai-Dorfman disease, the differential diagnosis comes into play of Rosai-Dorfman when you have this darker and lighter staining area. So there's this kind of funny resemblance to it. I mean, this is not Rosai-Dorfman because there's no peripoiesis or any of that. But it is an interesting thought that I read about how some cases of Rosai-Dorfman may be triggered by rhinoscleroma. Okay, so we can go on to our next case. So here's a smaller biopsy, a shave biopsy. And the first thing I notice here, pseudoepithelial hyperplasia. We got quite a bit of thickening of the epidermis. And we want to make sure we exclude squamous cell carcinoma by looking for atypia and all that. But once we've done that, then we have to think about what's causing pseudoepithelial hyperplasia, because it's not something that really generally occurs by itself. Often it will be associated with something. So we have to think about what lies beneath, what's going on underneath here. But before we do that, we also want to see if there's anything else, any other kind of inflammatory patterns that are accompanying this. And indeed, we do see that. We can see it over here, 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 and here. So these are collections of neutrophils or suppurative inflammation, and they're actually also intermixed with some areas of histiocytes over here. So this is suppurative granulomatous inflammation. And whenever I see that pattern, all those things combined, the pseudoepithelial hyperplasia with the suppurative granulomatous inflammation, you really have to think about infectious processes. And as a matter of fact, as you've probably already seen, there we go. There's our golden yellow round structures, which is our sclerotic or medlar bodies or copper pennies. And as you've probably guessed, this is a very nice example of chromoblastomycosis. So So chromoblastomycosis caused by a lot of things which I just don't have the energy to pronounce here, many of these bugs, which you probably have to know for your board exams. And the important point from the histology standpoint, the pseudoepithelial hyperplasia with tuberculoid and suppurative granulomas. And of course, we talked about the sclerotic or medlar bodies or the copper pennies, which is thought to be this intermediate vegetative form. And this is one of the fungal infections that you can see really nicely on H&E. You really don't need special stains to see it. Here's another example I wanted to show because I thought it had even more bugs on it, so it was very nice to see them represented here. A little bit of pseudoepitheliomatous hyperplasia over here, but lots of dermal suppurative inflammation over here, some ulceration, and zooming in, we can really see these beautifully represented copper pennies or sclerotic or medlar bodies right here. Just very nice, tons of them, lots of them. Some of them seem to be even expelled from the epidermis over here. Very nice representation of it. Okay, so we can go on to our next case. So here we got a case, contrasts a little bit from the other cases that we've seen, because we have not much going on in the epidermis, not much going on in the dermis, very little inflammation. But what jumps out, at least to me right here, is that we've got some thrombi. We've got medium, maybe large-sized vessels here and here that have thrombosis in them. So if you see that, you got to make sure you go closer and see if there's anything causing the thrombi, anything within the thrombus itself or within the vessel wall. And indeed, we do have that here. We have these slender, rigid sort of appearing septated hyphae right here. Some of them may be branching at acute angles, maybe hard to tell right there. But this is a nice example of aspergillosis. So it rarely involves the skin, and these are often very sick, immunocompromised patients. And as we saw in the histology, it invades the walls of blood vessels. You can get thrombosis and necrosis, which correlates to the clinical appearance of a very necrotic type of clinical lesions. The septate hyphae branching at acute angles, very indicative of aspergillus, but not 100% diagnostic, because you can have other bugs that look similar to it, like Fusarium. So ultimately, you may have to do cultures. An interesting tidbit of information is mucormycosis and aspergillosis can actually, if they involve the subcu fat, can mimic the ghost cells of pancreatic panniculitis. So that's something to keep in mind if you see pancreatic panniculitis. It could be the differential diagnosis, could be aspergillus or mucormycosis. And GMS stain will nicely highlight aspergillus. So we can go on to our next case. So here we have a biopsy that doesn't have a whole lot of intact epidermis. We have some maybe ulceration here. It looks like actually neutrophilic exudate right here, some neutrophils in there, maybe ulceration up there. Same going on over here. And then what to me looks like kind of just this dead sort of dermis, dead stroma here. There's not a whole lot of inflammation there, not much seeming to go on, to be going on. So, and that's really one of the things with this organism is you have to be careful not to miss it, because you can see it and think that there's not much going on and that there's just a lot of artifact going on, when indeed this is actually the bug itself, this stuff right here. And I've heard the term ribbon-like appearance, which I think very nicely describes what's going on here. No septate and branching at 90 degrees, maybe right here and here. So as you probably guessed by now, this is mucormycosis. This is another opportunistic infection in very sick patients. The big thing to remember is that often these patients are diabetic or immunocompromised in other ways. Mucor is present widespread in the soil or decaying vegetable matter. Again, primary cutaneous infection rare. Secondary disease usually results from hematogenous seeding. And as I said earlier, it can look like artifact. It can look like degenerated forms of aspergillus. You can have, in some cases, invasion of vessel walls, although in this case here, we didn't have that. But easy to kind of just skip over, this is nothing, but this is actually the bug itself. I have another example, I think right here, which is not quite as extensive. Always follow the inflammation, so we can see there's some inflammation down here, and as we can get closer, it's suppurative inflammation. And the inflammation will pick out the pathology, both in infectious diseases and often in tumors, much more quickly than we can. And indeed, there it is. There's the bugs right there. There's another larger one right there. There's a few in right through there. So this is another nice example of mucormycosis. Hard to tell if maybe there was a vessel here at some point, could be. It certainly looks like there's some necrosis going on here, so that could have been the process. Here's another representation right here and here. It's a good example of mucormycosis. I like that ribbon-like description. I think that's probably the most helpful one. Okay, so we can go on to the next case. So here we have a little bit of also kind of changing pace. We can see that this is a punch biopsy that doesn't have a lot of inflammation. And it has this vesicle that's going on, and sort of half of it. It's a very nice a technique to do this biopsy because we have the normal over here, and then we have the abnormal area over here. And we certainly do have a vesicle of some sort, so we should determine the area of split. And as we go closer, you can see that there's stratum corneum up here and the rest of the epidermis down here. So this is indeed a subcorneal split. So whenever I see a subcorneal split, I think of a few things. Bullous impetigo comes to mind, so I want to look for neutrophils, I want to look for bacteria. But again, it's a pretty inert, kind of dry-looking specimens. I don't see any bacteria or inflammation there. Pemphigus foliaceus is another thing that you want to think about. You're going to need your direct immunofluorescence studies to exclude that condition. But this is, in fact, an example of Staphylococcus scalded skin syndrome, which looks similar to those conditions. And all three of those, actually, in staph scalded skin, in bullous impetigo and pemphigus foliaceus, you get targeting of the antigen desmoglein 1. So it makes sense that you would have the split in a similar place in all three conditions. In Staphylococcus scalded skin syndrome, it's the exfoliative toxin, both A and B, that targets the desmoglein 1. Nasal carriers of Staph aureus are often at risk for this condition. And again, here's the differential diagnosis that I mentioned. TEN in particular, I wanted to mention toxic epidermal necrolysis because it's it's really a true derm emergency, and on frozen section and pathology, it can be very helpful because you can determine the level of the split. In TEN, you'll get full thickness necrosis and subepidermal splitting, whereas in staph scalded skin, you'll just get what we just had here, subcorneal splitting. So good to know if you have an emergency, you can always do a frozen section to distinguish those two. Okay, we'll go on. So here we have a very generous biopsy. And again, a very diffuse infiltrate within the dermis, very heavy infiltrate. At this power, you may already be able to tell that it's granulomatous. It has that clustering of epithelial histiocytes. But even before that, we can kind of tell it has this peculiar shape to it. I kind of call it this kind of snake-like shape to these granulomas. They're coursing around a lot of adnexal structures. So you can see right here, they're going around eccrine glands. They may be going around nerves in some areas, and they're going here deep into the fat as well. And I mention that because it can be a handy feature in diagnosing this condition. So if we can go closer, we can see that a lot of the histiocytes have that sort of traditional pink cytoplasm, but some of them also have this very kind of foamy, almost bluish appearance to it. And this is because these cells are full of the bacteria of what this is, and also lipid. So you may have guessed by now that this is Leprechaunism leprosy. These are called Virchow cells. They're just chock full of bug of organisms. If you do a fight stain, these are going to be really, really full of that, nicely represented here. In some cases, you can have so many of these foamy cells that you can even have an appearance of a xanthomatous lesion. So if you want to do your fight stain, you can and show that these are all bugs. And that's in contrast to this condition over here. Oops, I think we just, sorry about that, had to restart Path Presenter. But here we go where we just left off. The contrast to Leprechaunism leprosy, we have this condition right here, which is tuberculous leprosy, in which we have fewer granulomas infiltrate, but we have much more, as the name implies, kind of this tuberculoid quality. We have our granulomas right here in center field, and then we have this surrounding lymphocytic infiltrate. And the big contrast between tuberculous leprosy and Leprechaunism leprosy is that you will see very few bugs in tuberculous leprosy. So you may do your fight stain, you may do several of them, and you can see maybe a few, if any at all. So it's a striking contrast between the two types of conditions. Sometimes this can mimic sarcoidosis, so keep that in mind. You always want to go down your granulomatous differential and think about all possibilities before going down one train of thought. So here we have our kind of little summary of what we just talked about. Remember that extension down the nerves, down to nexostructures is a very handy feature to think about leprosy, make you think about leprosy. So we can go on to our next case. So here is what I see, a pseudocyst, and we have lots of inflammation, and that kind of what defines a pseudocyst. The pseudocyst is a cyst that has no lining. No true epithelial lining, I should say. And this one, the pseudocyst is lined instead by a lot of inflammation. It looks like granulomatous inflammation, maybe some multinucleated giant cells over here. So if you're going too quick, you might think, well, this is just a ruptured cyst, next case. But of course, that's not what's going on here. We have to look a little bit closer. In general, the suppurative inflammation might lead you to think there might be something more going on here. And indeed, if you do go close to the giant cells, you can see that there's these pigmented hyphae over here. So we have a condition here known as hypomicosis. I've seen a couple of these cases, and in some of the cases I've seen, what's a very handy feature is the fact that you'll see a wood splinter. Unfortunately, we don't have that here, but it's still a very nice representation. So hypomicosis, because it's an external process, so it occurs from implantation from traumatic injury. So that's why you would see the wood splinter in some cases. A good representation of this bug over here. We can see it over here. You can see it over here, actually. And another one of these, because it's pigmented, that you don't necessarily need to do your bug stains. So here is summary. Several species can cause this. Pigmented hyphae, as we just saw, and you get the pseudocyst or chronic abscess in the lower dermis or subcutis. As I mentioned before, sometimes the wood splinter, which is very nice to see, and brown or pigmented filamentous hyphae. This is different from chromoblastomycosis, which you get this round, sclerotic, or medlar bodies. Okay, we can go on to our next case. So here we see this shade biopsy that has sort of an ulceration right in the middle there. And unfortunately, we can't tell what happened to the epidermis there because of the ulceration. We can't tell if there's a lot of pseudoepitheliomatous hyperplasia or not, but that's okay because we still got a lot of things going on within the dermis here. And if we go close, we can see that there's quite a bit of granulomas again and quite a bit of suppurative inflammation. So we have well-defined suppurative granulomatous infiltrate with a lot of inflammatory cells next to it, which are probably a lot of plasma cells, interestingly. But again, if you see this in everyday practice, a suppurative and granulomatous infiltrate, start looking for the bugs. And indeed, if we go closer, we can see right here. There they are right there. There's another one right there. So this is another one that's fairly easy to recognize just on histology and routine histology without necessarily doing any special stains. And a lot of the reason is because these are very large bugs. You can see them very nicely represented here. These are spherules or sporangia, and they range in size anywhere from 10 to 80 micrometers. And you may have guessed by now, this is a really nice example of coccidiomycosis. So here's our summary. Most often self-limited pulmonary infection from inhalation of arthrospores, usually in the Southwest United States. Disseminated disease only occurs in less than 1%. Often these are immunocompromised patients. And again, that's a theme that we've been seeing a lot with these infectious organisms, where disseminated disease occurs in immunocompromised patients, and primary cutaneous disease is actually fairly unusual. The face is, interestingly, is the most common location. And as we're seeing here in this slide, you get a lot of granulomatous inflammation, sometimes pseudoepitheliomatous hyperplasia, but only in about a third of cases, which explains probably why we're missing it here. And again, these bugs are very easy to see. We can see them over here. So usually not too difficult to make the diagnosis. Here's one in this giant cell, which is kind of cool looking right there. So it makes it likely that you'll see this again on your board exam just because it's so readily identifiable. Here you can even see a little bit of the endospores in here as well. So these sporangia are very, very diagnostic. So we can go on to our next case. So this one is one where we have a little bit of ulceration, shave biopsy, maybe some erosion here, but not much else really going on with the epidermis. Again, we have a very brisk dermal process. And we can see that if we go close, a little closer here, maybe this piece. Again, a granuloma, this infiltrate, lots of diffuse proliferation of granulomas, these epithelial histiocytes clustering together. But closer yet, we can see that there's something else going on. We see these little foreign organisms right throughout here. And what's interesting about these is that they have this sort of clearing out around them. And that's a clue because this bug is actually producing a lot of mucin. So you may have guessed by now, this is an example of Cryptococcus, which is an encapsulated yeast-like fungus. The origin is from dried bird excreta. And like many of the other fungus we've been talking about, respiratory involvement is usually where it starts, and you can get cutaneous involvement in 10 to 15% of cases, usually immunocompromised patients. A lot of times these are HIV patients, as a matter of fact. And there's another version of it because of that mucinous capsule or mucinous capsule that Cryptococcus has. You can have this gelatinous variant, which can mimic and be mimicked by sweet syndrome. And I'll show you what I mean by that. So here's another example of Cryptococcus. And if you kind of do a glance at this, you might think, well, there's this dermal edema up here. And so I have to think about sweet syndrome or something in that differential diagnosis. But in fact, though, if you go at the interface over here, you can see that, in fact, you have the bugs right there. You can see nicely represented here. A little harder to see in the pale areas, maybe throughout there. But I think it's a little easier to see right over here in this area here. So as I said, this can mimic or be mimicked by sweet syndrome. Sometimes sweet syndrome, the histiocytic variant, can have cells that look like Cryptococcus. So what you can do is, in Cryptococcus, you can do your Alcian blue or mucicarmine, which will highlight the mucinous capsule that's surrounding pale area. And the cell wall is highlighted by PAS, Montanameson, or GMS stains. So we talked about that, and we talked about, and we saw examples showing the nice dense chronic inflammatory cells and granulomas of Cryptococcus. So we'll go on, next case. So here we see a biopsy that's a punch and that has fairly unremarkable epidermis, maybe a little bit of solar damage here, sun exposed area. But again, always follow the inflammation. You can see there's, from this power, what looks like suppurative inflammation. And right at the center, something that's very, very hard to miss. And you got this very purpley clustered looking thing with surrounding eosinophilic zone. So the bunch of grapes is kind of the term I've used or I've heard used, and I think is very nicely describes what's going on here. And this eosinophilic zone is actually immunoglobulin. It's a Splendori-Hoffli phenomenon, which you see in association with bacterial infections. So this is a nice example of Botryomycosis. It's a mycetoma, so you have to think about the other mycetomas such as actinomycetes, nocardia, or true mycetomas, fungi. You can do your special stains. I'll show you the cheat sheet. You can do your special stains to help differentiate, of course, your gram, your GMS, your PAS, although remember the eosinophilic zone can be PAS positive, or your acid-fast stains. But I think actually this is one that's fairly readily identifiable without any special stains. It's very characteristic. It's that, again, like it has been described, the bunch of grapes. So because it's easy to identify, probably going to be at some point on your exam. So be familiar with this one. And this is usually caused by Staph aureus, although you can have gram-negative bugs as well involved. All right, we'll go on to our last case. So here we see kind of a chopped up specimen, but one that has usually try to look for the epidermis and see if there's anything going on with it. A lot of the epidermis, unfortunately, has been kind of worn away or eroded away, but we do have some here, some outline. A lot of it's necrotic, but an outline of what looks like pseudoepitheliomatous hyperplasia. So that's often a clue, as I talked about earlier, when you see sort of pseudoepitheliomatous hyperplasia mixed in with a lot of this inflammation, which in this case happens to be suppurative inflammation. These are all neutrophils. Then you should think about infectious processes. We saw an example of chromoblastomycosis earlier, but this is another one that you need to think about. And if you go closer, you can see this is chock full of the bugs over here. And this particular example of this infection, you usually don't see this many organisms or this many bugs. So this is not something you would expect to see, but it is nice to see to kind of determine the morphology of it. Size is important because these are roughly, say about the size of a keratinocyte, roughly 7 to 15 micrometers. Some of them may have this double cell wall, so I'm giving away all the buzzwords by now. Haven't really seen good broad-based budding, but by now you should know that this is a nice example of North American blastomycosis. So endemic to the Mississippi, Missouri, and Ohio River basins around the Great Lakes area. This is where I'm from, so something we might see around here. Most cutaneous lesions, again, disseminated disease often starts in the lungs. Primary blastomycosis, primary cutaneous blastomycosis is pretty unusual. And this pattern, again, is pseudoepitheliomatous hyperplasia, the mixed inflammatory infiltrate with these giant cells, in particular with the neutrophils and the microabscesses or the suppurative granulomas. And we talked a little bit about the morphology. These are, as I said, roughly maybe a little larger than the keratinocytes, 7 to 15 micrometers. Sometimes you see the broad-based budding. If you need to do stains, you can do the PAS or GMS stain. And often you do because, as I said, this is an example that has quite a bit of bugs in it. I wonder if this patient is immunocompromised. But nevertheless, very nice to see the morphology of these fungi right here. So differential diagnosis, that pattern again with pseudoepitheliomatous hyperplasia can include chromoblastomycosis and non-tuberculous mycobacteria. So Chelonia or other bugs like that can have that sort of same pseudoepitheliomatous hyperplasia and suppurative granulomatous picture to it. It's a really good example of that. And actually that is the last case I have. So thank you. I hope everyone is staying safe and healthy. I hope this was helpful. And I hope we shared in some interesting cases. And thanks for your attention.